Hi. Can you hear me? Okay. So I am going to respond to questions from Section A, Section I. So the first question we received asks, with regards for the gender question, how does CMS want transgender patients coded? And at this time, CMS does not offer standard guidance. And if this changes, an announcement will be made, and providers should refer to their facility policy when coding gender. Okay, the second question is from Section I, and the question is, how does CMS define severe for the cancer and systolic ventricular dysfunction? So the way that we defined it for the ventilator liberation quality measures, because those are risk factors, is that we use the hierarchical condition categories, the HCCs. And so for HCC 8, that is a severe cancer, HCC, and then you would follow the ICD-10 codes that map to that particular HCC. And in my presentation this morning, I gave you an example of an ICD-10 code associated with that particular HCC. HCC 9 is the metastatic cancer HCC, and again, you would use the ICD-10 codes that would map to that HCC. And I also gave an example of that in my presentation this morning. I've written the response, but it's just not showing up here. So I could give you those specific ICD-10 codes. And then regarding how is the left systolic ventricular dysfunction defined, we're defining it for the purposes of the LCDS because we appreciate that there's different levels of heart failure. But for the purposes of the LCDS, and again as a risk factor for the ventilator liberation quality measures, it's an ejection fraction of less than or equal to 30%. The next question is from Section I, Active Diagnosis, and it says, please clarify documentation necessary to support I-5602, which is at risk for malnutrition. And the inquirer says at risk for is not an accepted medical diagnosis, so docs are hesitant to write it. Is dietitian documentation adequate for this specific data point? And at this time, what we CMS would like to do is we want to investigate this one a little bit better so that we can give an appropriate response. As you probably know, the guidance in the LTEC QRP manual for version 4.0 is silent on the documentation that gets to the level of specificity that this question is asking. So we will respond to the question. The next question for Section I is active diagnosis. I-2600, what are some examples of opportunistic infections? And the responses, they are caused by pathogens, bacteria, viruses, or fungi that take advantage of an opportunity not usually available to them. And next I'm going to give this to Ann and Carol for Section GG.
Thank you, Terry. So the first question that we're going to answer on Section GG is, how would you code a 600-plus pound patient who needs 2 people to assist for staff safety to get out of bed, however, is independent once up performing his tasks, for example, oral care, based on the slides, if required, 2 helpers to complete the task would be coded as dependent, but in this case, he really isn't. So our response is that each activity includes a number of tasks per that item's definition. Your clinical judgment of the summary of the patient's performance and need for assistance for the tasks results in the coding of the specific activity. Code the activity based on the amount of assistance the patient requires. In the scenario provided, the patient needed for 2 helpers to transfer from one surface to another. For example, GG0170D, sit to stand, may require 2 helpers and thus be coded 01 dependent, while other items, such as section GG0130A through D, may be coded as more independent because those activities do not require transfers. And lastly, an example is for GG0171, walk 10 feet. Per the item definition, it is to be assessed once standing and does not require consideration of the patient's transferability from sit to stand, only the patient's ability to walk 10 feet. The next GG item that we'll answer is, please give an example of when and why you would code 07, patient refused, as a discharge goal for a self-care or mobility item. So our response is we expect use of a discharge goal of code 07, patient refused, for LTAC patients to be rare. Just a reminder that a minimum of 1 discharge goal is required for either a self-care or mobility, the GG0130 or GG0170 items. This coding applies to other settings and may be used in IRFs, for example, for 12 steps. The next GG item we were asked was, when querying the patient family for usual performance, is it the expectation of CMS that this conversation be coded in the EMR, or is documentation of the care data tool sufficient? So our response is, for prior functioning, the patient status would be documented in the medical record. The information in the medical record would be expected to be consistent with the information coded on the LCDS. Next question is, admission functioning code should reflect usual performance and the patient's status prior to therapy. Should the LTAC avoid providing therapy during the 3-day admission assessment reference period? And our response is no. The admission assessment should be conducted as soon as possible. We provide more information about the LTAC provider in the LTAC provider manual posted on the CMS website. The assessment can be completed on the same day of admission or the morning of the next day of the patient's stay to ensure a baseline assessment of the patient's functional ability. Another question, using the logic tree regarding using 2 helpers means that the patient is classified as dependent, but staff are encouraged to help each other to decrease stress and injury. Using the decision tree solely would result in overclassification of dependence. Is the 2 helper equal dependent flexible? So when coding a clinical assessment of the patient's functional performance, allow the patient to be as independent as possible. You may not consider each time the patient performs an activity as an assessment. Did you want to add something?
So I think, one of the points that we wanted to convey is a patient may, for example, take a long time to eat, just as one example. And so maybe if the person is going to therapy or, wants to go out with family or something, it may be the patient's in a bit of a hurry and the staff say, okay, well, I'll help you more than you really need. And so in that case, I wouldn't consider that episode of eating when I'm thinking about the patient's ability, because in that instance, I helped the person more than they really needed to. So think about the instances where a clinical assessment has been done where the person is allowed to be as independent as possible, and then among the assessments, assessments that are being done, where you're still able to determine the person's baseline status, that's where you're looking for how the patient's doing and any potential variation. So I hope that helps. Okay, I'm going to keep going. Okay. So the next one, usual performance has proven to be highly variable, leading to most frequently reporting code in documentation. Is this correct? So I think the example I just gave kind of is related to this response also. So the intent of the admission assessment is to establish the patient's baseline functional status at admission. If the patient is assessed multiple times during the assessment period and the patient's status varies, do not report the most dependent episode or the episode where the person is the most dependent. It should basically represent the person's status that is best represents their baseline status. Yeah, so I think that's that response. Okay, another question, slide 29. Is the and/or in the patient needs verbal cueing and contact guard, but not lifting, is code 4 appropriate? So for code 4, which is called supervision or touching assistance, it can include any or all combinations of assistance, including verbal cues, touching, contact guard, any of that type of assistance. It could be constant cueing or a little bit of cueing or a little bit of touching and some verbal cueing, and that would all be coded for as long as there's not lifting assistance or actual assistance with the activity more than touching. Okay, next one. So in relation to section GG, what is this data used for at CMS? So the data were added to the data sets, added to the LTAC Care data set in order to allow CMS to calculate quality measures for the LTAC quality reporting program. And it is CMS's intent to publicly report those data as they become available. And so that's the intent. So there's actually 3 quality measures related to function at this point in time. I mentioned the outcome measure, and there are also 2 process measures. Okay. Next one, is it really necessary to ask manual versus motorized type twice for the wheelchair? Seems to be repetitive. So the purpose of reporting the type of wheelchair for the 2 different distances is that in some instances, patients may be able to use one type of wheelchair to go shorter distances, but may use perhaps a motorized wheelchair to go longer distances. So for some patients, they may use different types of wheelchairs. So yes, we do actually ask for that information twice in order to determine if it's the same type of wheelchair or different types of wheelchair. Okay, next one builds on a question actually that Carol answered about goals. And so there was a question about coding 07, and Carol said, we don't expect that really to be coded in the LTAC setting. And somebody else asked, what about code 9s, 10, and 88? Would they be coded as discharge goals? So as Carol stated, 07 wouldn't typically be expected to be coded as a goal. But, based on the help desk questions that came in from the LTAC setting as well as the IRF setting and the SNF setting, there was interest in allowing these codes to be used for goals. And so CMS allowed all of them. And as Carol stated, coding, there's only one that's actually required for the process measure. So Carol mentioned 7. We don't expect that to be used really, or it would only be rarely used. And then for the code, let's see, 09, Carol came up with an example that I thought was good. So somebody who, let's say, for many years has not been able to eat by mouth. So let's say they have a long-term swallowing problem and from an old stroke or brain injury, and the person has not eaten by mouth for many years. And so the person is admitted. They are an 09 for their admission assessment. The goal may be that they continue at that status, and so that could be potentially an 09 goal. Again, don't think that would be common, but I think, a reasonable example that Carol came up with. Let's see, 10. So I don't think we could come up with an example for 10 for the LTAC setting, but maybe one of you will come up with an example. We'll see it in the data, perhaps. And then code 88, I think, again, we don't think it'll be commonly used, but again, maybe in one of the other settings, for example, where stairs or picking up an object from a standing position is used, maybe it might be used for those. But again, these are options for you, but certainly we would encourage you to code 1 through 6. And I think, some of the examples Carol and I were trying to talk through while we're working on these. If somebody maybe would like a family member to help them do an activity, in that case, it may be the patient's goal that they are dependent, but the activity of eating or oral hygiene or whatever activity would be 01 in that case. Remember that when you code 07, 88, 9, and 10, that means the activity didn't occur. So in like people normally would be eating unless they're on tube feeding, which was that example that Carol came up with. But if somebody says that, they don't want to feed themselves, they want their family member to feed them, the goal in that case is 01, dependent. They are eating, it's just their goal perhaps might be to be dependent. Okay, scenario 11 provides status at admission throughout the stay and at discharge. Should the discharge goal reflect status in the discharge assessment or the usual status documented in the record throughout the stay? So the answer we have for that is usual status is generally referring to the admission status. A discharge status assessment is the status of the patient at discharge. Okay, next one. Please explain the difference between the functional status measures and the application of functional status measures reported separate line items. So this relates to the quality measures. So as I said, the data, section GG data are collected. When CMS gets the data, there's analysis of the data into quality measures. So for the LTAC setting, there are actually 2 function quality measures that are process measures. The first one, which is the original measure that was finalized, it was developed specifically for the LTAC setting. And so that measure has more items that are required as part of the functional assessment. The second measure was actually implemented in all the post-acute care settings and is meant to be a cross-setting version of the LTAC original measure. And so the cross-setting measure is limited to self-care and mobility items, whereas the original measure includes additional items in the area, section BB, the communication items, the CAM, which is in section C, and also the bladder item in section H. So basically, the difference between the measures is that the original LTAC specific measure has more items on the admission and discharge assessment covering section BB, C, GG, and H. The cross-setting measure only addresses section GG. If you're interested in the differences, you can actually look it up in the quality measure user's manual, which I talked about at the end of my section GG presentation, and specifically the table 7.4 in that manual speaks to the original LTAC quality measure, and table 7.5 gives the details for the cross-setting quality measure. So everything that I just explained is laid out there in detail. Okay, another question. Okay, it looks like this might be the last one. Why is it important to be exact on the GG codes? For instance, why does it matter that a person needs some physical assistance more than half, less than half? So these codes differentiate different types and levels of assistance that a patient may require when performing daily activities. So the rating scale was developed with input from technical expert panels about 10 years ago at this point. And in our analyses, one of the things that we do is we look at the codes for each item, and we've done this actually for the IRF, LTAC, and SNF settings, the data, and patients who are coded 1 versus patients who are coded 2, 3, 4, 5, and 6. On each of the items, when we've looked at the data, the likelihood of going back to the community increases with each of when people are coded the higher levels. So these are important differences. It makes somebody is definitely more likely to go home if they get coded a 3, for example, versus a 2. And we see this across all of the items. So those are important differentiations. And that is the last question.